Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Today the topic of our presentation is the examination of semen. We it is also called semen analysis. It is done in case of male infertility and other diagnostic tests if required. So, male infertility is the failure of a couple to achieve conception within 12 months of advocate unprotected coitus or sexual relation. About one third of cases of infertility results from pathologic factors in men, one third from factors in both men and women, and one third from factors in females. Male causes therefore account for 50% of infertility. About 15% of all married couples experience reproductive difficulties. Causes. For practical purposes, the main causes can be divided into three categories: treatable causes, potentially treatable causes, untreatable causes. So, causes of male infertility: treatable causes, varicocele, infection of testes, epididymis, urethra, prostate, ejaculatory dysfunction, erectile dysfunction, hyperprolactinemia, hypogonadotropic hypogonadisms. These are the treatable causes. Potentially treatable causes: it may be idiopathic, undescended testes, gonadotoxins, drugs or radiations, blockage of vas deferens. Untreatable causes are congenital abnormalities, that is, absence of both testes, and also chromosomal abnormalities, bilateral testicular atrophy. Symptoms: patients usually complain of their wife's inability to give them a child. Such patients are quite often very apprehensive, frustrated, and reluctant to undergo investigations. Symptoms suggestive of history of STI, sexually transmitted infections, urinary tract infections, mumps, genital, pelvic or inguinal-scrotal surgery, and injuries. The signs: absence of male secondary sexual characteristics, gynecosmia, examine external genitalia to assess. Testes presence or absence, size and consistency, epididymis thickening, vasodifferential absence or thickening, varicocele is an enlargement of the veins within the loose bag of skin that holds testicles, the scrotum. Inguinoscrotal inguinoscrotal region scar from previous hernia, hernia frebi. Penis size, curvature, hypospadias, epispadias. These are the name. Urethra discharge, metal stenosis, and abnormal narrowing of urethral opening, meatus stricture. Investigations may be required: full blood count and the sickling, that is, sickling test, which is done in case of sickle cell anemia. The second number investigation required is semen analysis, the urine analysis, fasting blood glucose, specific investigation related to various causes, that the scrotal ultrasound, and specialized investigations, for example, a hormonal profile done by specialists, that is follicle stimulating hormone and the luteinizing hormone, etc. Evaluation of female partner by a gynecologist. Now, semen. Semen, also called seminal fluid, fluid that is emitted or ejected from the male reproductive tract and that contains sperm cells which are capable of fertilizing the female's egg. Analysis: when investigating infertility, the basic analysis of seminal fluid usually include is the measurement of volume, the measurement of pH, examine a wet preparation to estimate the percentage of motile spermatozoa and viable forms and to look for cells and bacteria. Sperm count, examination of stand preparation to estimate the percentage of spermatozoa with normal morphology. Collection and transport of semen, 3 to 7 days of sexual abstinence. Write name of the patient on the container, date and time of collection, period of absences and delivered the specimen to the laboratory within 1 hour after collection. During transit to the laboratory, the fluid should be kept as near is to body temperature. This is best achieved by placing the container inside a plastic bag and transporting it in a pocket in the person's clothing. Measure the volume. Normal semen. Normal semen is thick and viscous when ejaculated. Normal semen is thick and viscous when ejaculated. It becomes liquefied usually within 6 minutes, 60 minutes due to the due to a fibrinolysin in the fluid. When liquefied, measure the volume of the fluid in milliliters using a small graduated cylinder. Normal specimens usually 2 ml or more. The second number is to measure the pH. Using a narrow range pH paper, that is pH 6.4 to 8.0, spread a drop of liquefied semen on the paper. After 30 seconds, record the pH. pH of normal semen should be 7.2 or more within 1 hour of ejaculation. When the pH is over 7.8, this may be due to infection. When the pH is below 7.0 and the semen is found to contain no sperm, this may indicate dysgenesis, failure to develop of the vessel differences and seminal vesicles or epididymis. Estimate the percentage of motile and viable spermatozoa. For motility, place one drop of that contains 10 to 15 microliter of well-mixed liquefied semen on a slide and cover with a 20 into 20 mm or 22 into 22 mm cover glass. One drop falling from a 21-gram needle is equivalent to volume of 10 to 15 microliter. Focus the specimen using a 10x objective lens. Close the condenser iris sufficiently to give good contrast. Ensure the spermatozoa are evenly distributed. If not, remix the semen and examine a new preparation. Using the 40x Using the 40x examines several fields to assess motility, that is whether excellent, rapid, or progressive, or weak, slow, and non-progressive. Count a total of 100 spermatozoa and note out the 100, not out of the 100 how many are motile. Record the percentage that are motile and non-motile. Normality or normal motility: over 50% of spermatozoa are motile within 60 minutes of ejaculation. The spermatozoa remain motile for several hours. When more than 60% of spermatozoa are non-motile, examine an eosin preparation to assess whether the spermatozoa are viable or non-viable. Presence of cells in semen. Report when more than a few leukocyte pus cells or red cells are present. When pus cells are seen, examine a gram stain smear for bacteria. For viability, mix 1 drop of 10 to 15 microliter of semen with 1 drop of 0.5 eosin solution on a slide. Dissolve 0.1 gram of eosin in 20 ml of fresh physiological saline. After 2 minutes, examine the preparation microscopically. Uh, Use the 10x objective to focus the specimen and 40x objective to count the percentage of viable and non-viable spermatozoa. Viable spermatozoa remain unstained and non-viable spermatozoa remains stained red. Normal viability: 75% or more of spermatozoa should be viable and stained. A large proportion of non-motile but viable spermatozoa may indicate a structural defect in the flagellum. Perform a sperm count using a graduated tube. Small cylinder, dilute the semen 1 in 20 as follows. Fill the tube or cylinder to 1 ml mark with well mixed liquefied semen. Add sodium bicarbonate formalin diluting fluid. Using a Pasteur pipette, fill an improved newborn chamber with well mixed dilute semen. Wait 3 to 5 minutes for spermatozoa to settle. Using 10x with the condenser iris closed sufficiently to give good contrast, count the number of spermatozoa in area of 2 square millimeter, that is 2 large squares. Note the total area of improved newborn chamber and a bulk rule chamber is 9 square millimeter. that is 9 large spheres. Calculate the number of spermatozoa in 1 ml of fluid by multiplying the number counted by 100,000. Normal count 15 million to greater than 200 million sperm per liter of semen. Count less than a count below 15 million is considered abnormal. Estimate the percentage of spermatozoa with normal morphology in stand preparations. Make a thin smear of liquefied well mixed semen on a slide while still wet. Fix the smear with 95% volume by volume ethanol for 5 to 10 minutes and allow to air dry. Wash the smear with sodium bicarbonate formalin solution to remove any mucus which may be present. Rinse the smear with several chances of water. Cover the smear with dilute 1 in 20 carbol fustian and allow to stain for 3 minutes. Wash off the stain with water. Counter stain by covering smear with dilute 1 into 20 Loeffler's methylene blue for 2 minutes. Wash off the stain with water. Drain and allow the smear to air dry. Staining result nucleus of head would be dark blue. Cytoplasm of head pale blue. Middle piece and tail would be pink to red. Morphology of spermatozoa. Examine the preparation of normal and abnormal spermatozoa using the 40x of microscope. Use the 100x objective to confirm abnormalities. Count 100 spermatozoa and estimate the percentage showing normal morphology and the percentage that appear abnormal. Note: laboratory staff who have not been trained to report stand semen preparations should request the assistance of a specialist cytology laboratory. Normal spermatozoa measure 50 to 70 micrometer in length. Each consists of an oval-shaped head with acrosomal cape, which measures 3 to 5 into 2 to 3 micrometer, a short middle piece, and a long thin tail at least 45 micrometer in length. In normal semen, at least 50% of spermatozoa should show normal morphology. Most specimens contain no more than 20% abnormal forms. Abnormal spermatozoa. The following abnormalities may be seen: head greatly increased or decreased in size, abnormal shape and tapering of head pyriform, acrosomal cape absent or abnormally large, nucleus contain vacuoles or chromatin is unevenly distributed, two heads, additional residual body that is cytoplasmic droplet. Middle piece may be absent or markedly increased in size, appears divided bifurcated, angled where it meets tail. Tail may be absent or markedly reduced in length, double tail, bent or coiled tail. And that's all for today. See you.